And I get to stand throughout the whole presentation because there are no more chairs left on the podium. No, it's my pleasure to be here discussing, I think, this very important topic and taking TAVR to the next level. So I think the key message and the foundation is that, being involved in the TAVR trials since their inception, the clinically reported data of 1 to 2% stroke rates is actually belied when you have systematic neurologic assessment of these patients. I mean, even in the most recent data set, even from the Claret trial, it was unprotected TAVR had a 9% stroke rate, which is important. And this is important on many levels. First of all, it's devastating in terms of mortality impact. You have almost a 70% mortality after a 1-year mortality after a stroke, going up to 83%. So it's a devastating injury. In terms of those who survive, 40% have a moderate to severe functional disability, and even the majority would have at least some residual dysfunction. And even more importantly, I think, as we move into, I'm sure we will be in low-risk approvals over the next 12 to 24 months, it still has an effect in terms of only 40% will return to work, causes a lot of financial strain. And also, any of us who've been sick know what a permanent disability can do in terms of social isolation and depression and all the ancillary effects on quality of life. Alexandra led this trial, which was looking at the contemporary outcomes in terms of TAVR and unprotected TAVR in 5 centers, and when you looked at 30-day, VARC2 stroke Rankin scores, NIH stroke scales, it's 22% in hospital, a rate of deterioration in NIH stroke scale, and MoCA, when you really did a careful analysis of cognition, as many as 40% had a decline in cognition. So this is not a benign effect on the cerebral vasculature. And this is because virtually every step of a TAVR puts a patient at risk, whether it's crossing the valve, the valvuloplasty, the valve placement. And when you look at DW MRIs that we've known, 70 to almost 100% of cases show new lesion. And when you see these, on MRI, they're not benign. Their overt stroke is seen in a risk of 2 to 4 times. And more importantly, we know from other arenas that the more volume of abnormalities on DWI, MRI, it increases the risk of dementia. And as we get into a younger population and a healthier population, we have to keep this in mind. But it's not all about volume. This is just some MRIs from the Sentinel trial. As you can see, varying sizes. Here's a tiny defect. Here's a very large defect. Here are multiple defects. But all these individuals had disabling stroke. So it's location and not size. But importantly, there are 2 factors where we can actually affect this, and we've seen this from the earliest TAVR days, but a more updated analysis from the partner trial of 2,600 patients shows that it's mainly an acute phenomenon, peaking in the first 2 days and then leveling off after that with a constant low risk of about 0.8% per year. So this is peri-procedural, and it certainly gives us an opportunity to really abort this phenomenon by intervening during the procedure. And importantly, a mechanical solution seems to be the only way to have a major impact on the peri-procedural events, because when you look at the debris, say from the Claret filters, virtually half the patients have non-thrombotic issues like valve tissue calcification and even foreign material. So there's no interprocedural antithrombotic therapy that's going to abort this. And as we're learning more and more about these, and when you look at not looking details of the cross-valve phenomenon, but we see across all valves, we have high particle counts, we have total numbers of high particle areas, and very large particles with some of these valves. But the point is all the valves produce these particles. Another important aspect of it is, these strokes are equal opportunity employers when it comes to the vessels. Really, it's really all the territories are at risk, and that's why we believe that covering all these are important, given the fact that it's almost an equal division among the main trunks when you really analyze the origin of these defects. Now, in terms of the utilization of this, doing it selectively, I don't think is the answer. And this and other analyses have indicated it's very difficult to predict who's going to have a stroke. They're very varied and not really good discriminators. And even more recent analysis from the Sentinel trial reinforces this, that we really are very poor at predicting who's going to have these lesions or a clinical stroke. And another aspect to keep in mind from the patient perspective, when you talk about minor disabilities and the like, one of the most important things of patients when their expectations in health is, besides maintaining independence, it's the ability to do a specific activity. So even the most minor disability for an individual can have a real long-term impact on their lives. So it's preventing any neurologic injury, I think, is critical for it. Now, we do have some experience. A Sentinel trial. It's a two-vessel coverage device with capturing filters in the innominate and in the left carotid, and it was shown to be safe in terms of 30-day MACE. So it met its safety endpoint. But I think importantly, the primary endpoint in terms of reducing the protected territories, MRI defect volume was negative. And if you looked at the overall protected and unprotected territories, there was virtually no even numerical difference. And the question emerges from this study that would full coverage have produced a actual positive result on this endpoint? And that's the main question. So this emerges with the Triguard. As you can see, the Sentinel, as I mentioned, covered two vessels. But here we're discussing a technology that really sits across all three vessels in the aorta. And Tamim will describe this technology in detail, but our feeling is if this is helpful, maybe this will really get us to where we want with all three vessel coverage and really minimize the risk of stroke in TAVR. Now, the data that we have right now on this is limited but encouraging. We had the Deflect 3 trial with Alexandra helped lead, where with an older technology, but it was two groups randomized to the old Triguard and the unprotected TAVR. And what you saw here was when you looked at the number of non-ischemic lesions by intention to treat, patient with no ischemic lesions, total freedom, over 1/4 of the patients who had the Triguard had no lesions on their MRI, where it was only 11% in the unprotected group. And when you looked at again, you saw the same important trends in terms of worsening cognition or worsening NIH stroke scale, heavily in favor of the Triguard. And when you analyzed all the pooled analysis of Triguard from multiple trials, you start seeing significant differences in terms of significant reductions in VARC2 stroke, stroke association stroke, and NIH stroke scale, or MoCA deterioration, and of course DWMRI lesions. So the preliminary data from three-vessel coverage, even with a device that was not state-of-the-art, is highly encouraging. So I think, just to conclude, overt and covert strokes are significant and important complications of TAVR, which can be of great consequence, especially as we move to lower risk. The weight of evidence indicates that cerebral protection does reduce these events. By covering all three cerebral vessels with Triguard cerebral embolic protection, we may further reduce this risk, and we know it is safe and does not add to procedural risk. And Tamim will follow me and really describe the phase 2 trial of Reflect, which is underway, that will hopefully give us definitive evidence of the clinical efficacy of this technology. So thank you very much.